My name is Jonathan Giorentano, and I'm an assistant professor of otolaryngology head and neck surgery at MedStar Georgetown University Hospital in Washington, D.C. In this video, I will be discussing parotidectomy. Within the head and neck region, there are numerous glands that produce saliva, one of which is the parotid gland. Saliva is composed of water, minerals, organic compounds, and enzymes. Saliva has several functions, aiding in the first stages of digestion, providing lubrication and moisturization of the mouth and throat, and protecting the teeth. Within the neck, there are major and minor salivary glands. There are two major salivary glands on either side of the head and neck. The parotid glands are located just in front of the ear, and the submandibular glands are located beneath the jaw. Aside from the parotid and submandibular glands, there are also the sublingual glands, which are located underneath the tongue, as well as hundreds of minor salivary glands scattered throughout the inside of the mouth and throat. These minor salivary glands are very small, often around the size of a grain of rice. Tumors can arise from the salivary cells within any salivary gland. However, the parotid is the most frequently affected gland. The good news is that approximately 75 to 80% of parotid tumors are benign. However, some parotid tumors can be cancerous. Most often, parotid tumors develop as a lump in front of or below the ear. While most benign tumors are essentially asymptomatic, some malignant tumors may cause facial weakness, lymph node enlargement, or pain at the site of the tumor. A parotidectomy is the surgical removal of part of or the entire parotid gland. There are two different types of parotidectomy: superficial parotidectomy and total parotidectomy. Within the parotid gland is located a nerve called the facial nerve. The facial nerve travels throughout the parotid gland, giving branches that innervate the motor muscles of the face. The facial nerve is what allows you to raise your eyebrows, close your eyes, scrunch your face, and smile. The parotid gland located on top of the facial nerve is called the superficial lobe of the parotid gland, and the area of the parotid gland located beneath the nerve is called the deep lobe of the parotid gland. Most tumors originate in the superficial lobe of the gland, so identification of the nerve allows mobilization or removal of the tumor safely, with adequate margins around the tumor tissue and no injury to the facial nerve. This is called a superficial parotidectomy. When the tumor requires dissection both above and below the facial nerve, the procedure is called a total parotidectomy. A parotidectomy is performed in the operating room under general anesthesia. The incision for a parotidectomy is located in front of the ear, curving around the earlobe and either towards the hairline or onto one of the neck skin creases. Once the skin overlying the parotid gland is lifted to expose the gland and tumor, the facial nerve is then identified. After the nerve is identified, the segment of parotid gland containing the tumor is then dissected free from the branches of the facial nerve and removed. The incision is then closed in layers with dissolvable sutures. This incision generally heals very well with minimal scarring, and it provides safe access to identify the facial nerve and to remove all tumor tissue. Sometimes a parotid gland is removed even if there is not a salivary tumor present. The parotid gland also contains lymph nodes that drain the lymph from the skin of the scalp and forehead region. Sometimes skin cancers can spread to lymph nodes within the parotid gland. As part of surgery to address these skin cancers, the parotid gland may be removed not to specifically remove the salivary gland tissue, but to remove the lymph nodes located within the parotid gland. Additionally, some patients experience recurrent or chronic infections in the parotid gland. Sometimes this is due to stones forming within the gland, or other times it may be due to an underlying autoimmune disease such as Sjogren's syndrome. We generally try to preserve the salivary glands if at all possible, but if infections keep recurring despite conservative and minimally invasive surgical methods, parotidectomy may be necessary to remove the salivary tissue which is causing the recurrent infections. While there are several specific risks to parotid surgery, the risks of surgery are often in part determined by the specific anatomy of the tumor. As we discussed earlier, the facial nerve, the nerve that controls the motor function of the facial muscles, runs through the parotid gland. Great care is taken during surgery to identify and protect the facial nerve. I use a technology called intraoperative nerve monitoring to help identify the nerve and ensure that it is functioning throughout surgery and at the end of surgery before you wake up. With meticulous dissection of the facial nerve branches, most patients have normal function of this nerve following surgery. However, facial weakness can occur after surgery, even when the most meticulous dissection is performed. Weakness can either occur in one specific branch, in which case you might notice an asymmetry of one portion of the face compared to the other. For example, you might notice a crooked smile, a drooping of the smile crease, or an inability to wrinkle the forehead on one side. If all branches of the facial nerve are weak at the end of surgery, then you would notice an obvious drooping on one side of the face, like you might see with a stroke patient. Temporary weakness will usually recover within 3 to 4 months without the need for any additional therapy. Permanent weakness can occur, but this is rare if the nerve is visibly intact at the conclusion of the procedure. In the case that the nerve remains permanently weak after surgery, all hope is not lost, as my colleagues in facial plastic and reconstructive surgery have developed new techniques for performing facial nerve reanimation to help patients look and function normally. Wound infections are rare but may also occur and can usually be managed in the clinic with antibiotics and minor wound care. Bleeding into the wound site causing a hematoma is rare, but sometimes requires return to the operating room. As removal of the parotid gland requires cutting of salivary tissue, sometimes saliva may collect in the upper neck or drain through the incision line during the postoperative period. This can lead to a salivary fistula, a constant draining of saliva to the skin. Salivary fistula is usually temporary without the need for additional treatment. A common long-term effect of parotidectomy is called Fry syndrome. Fry syndrome is caused by the growth of salivary nerve fibers to the sweat glands of the skin during the healing phase. You can think of this as being an accidental rewiring of the nerves while the body heals. The hallmark sign of Fry syndrome is sweating over the operated side of the face while eating meals. This may be controlled by applying antiperspirant to the skin overlying the cheek. If this remains bothersome, the sweating can also be managed with in-office Botox injections. Another long-term effect specifically related to surgery in the parotid region is something called first bite syndrome. First bite syndrome refers to facial pain characterized by a severe cramping or spasm in the parotid region with the first bite of each meal that then diminishes over the next several bites. This is more commonly seen in surgery that requires removal of the deep lobe of the parotid gland. First bite syndrome is often treated with conservative measures or Botox administration if necessary. You must note that the ear and cheek will often be numb for several months after surgery. Sometimes patients experience a permanent numbness of the earlobe after parotid surgery, but this is rare. After surgery, most patients are observed overnight in the hospital to ensure a safe postoperative course. Once you are able to swallow liquids by mouth and you can manage your wound drain, you may be discharged back home. Most patients are discharged home within 24 hours of surgery. Patients leave the hospital with absorbable sutures in the wound site. Some patients go home with a drainage tube in place. This is a small plastic tube that exits the skin behind the ear and is attached to a plastic bulb that collects the blood, serum, or saliva collecting in the wound. No dressing was required to go home with. Once the drain output is less than 30 milliliters per day, the drain can be safely removed in clinic without discomfort. Drain removal is usually possible within 4 to 5 days after surgery. Yes, as Georgetown is an academic teaching hospital, residents and medical students are typically present for parotidectomy. Residents are physicians who have graduated from medical school, but who are learning the additional skills in the operating room and clinic to become surgeons. While I'm always in charge of the operation, complex head and neck surgery requires multiple sets of hands to be performed efficiently and safely. Once the operation is over, the residents serve as our eyes and ears for our patients who are recovering on the floor. One of our residents is in-house and on call 24 hours per day, so they are always on hand to help manage any issues that might arise. I firmly believe that the presence of residents and medical students in the hospital is a benefit to patient care. After surgery, I will have you apply a topical emollient such as Aquaphor to the wound twice each day. If you have a drain in place, you will empty the drain bulb twice each day and record the output. 72 hours after surgery, you may start to shower and let the water run across the incision. Once your sutures have dissolved, you may then start to wash over the wound with soap and water. I will have you apply Aquaphor, vitamin E, or aloe to the wound twice each day for a month after surgery. If you are going to be out and exposed in the sunlight, I will have you apply an appropriate SPF sunscreen over the incision to help prevent hyperpigmentation of the scar. After the first month of healing, you may use Mederma or a similar agent for 2 additional months to help optimize wound healing. Please note that the entire wound healing process takes up to 1 year to complete. If you go home with a drain, you will take an antibiotic at home while the drainage tube is in place. You will also be provided with a prescription for a pain medication to take on an as-needed basis. Expect to eat a liquid and soft diet for the first few days after surgery. Chewing may be uncomfortable due to irritation of the masseter muscle that lies below the parotid gland in the cheek. This gradually improves as you heal, and generally you'll be able to eat a normal diet approximately 1 week after surgery. In the postoperative period, if you develop a fever, have redness or increasing swelling or pain around the incision, or if you see drainage of pus from the incision site, please call my office. Mild hoarseness from the breathing tube inserted by anesthesia may occur on the day of surgery. This usually resolves within a day or two. You should call me or present to the emergency department if you have any increase in hoarseness, pain, swallowing problems, or any breathing problems. If you have any facial weakness after surgery that makes it difficult for you to fully close your eye, then you may be provided eye drops or lubricant to help keep the eye from drying, and you may be instructed on how to tape the eye shut at night. You will be seen in clinic for postoperative visits. Pathology results are usually available about 5 working days after surgery and are reviewed with you in clinic. Once the drainage tube is removed and the sutures are dissolved, you will then be seen in clinic every 6 to 12 weeks until healing is complete. Patients with malignant tumors are followed every 3 months for 2 years, then every 6 months for up to 5 years.